Okay, good morning, everyone. The people who organized the slides decided it's 8 o'clock, and so they put on the slides exactly on the second when it became 8 o'clock. I have to congratulate you all to wake up early this last day of the meeting to join this challenging session on navigating the cow's milk allergy journey from diagnosis to nutritional optimization. So I'm Yvan Vandenplas, based in Brussels, always been interested in pediatric gastro and pediatric nutrition. And we have three eminent speakers on our symposium. The first one is Professor Annamaria Staiano, now president-elect of ESPGHAN. So congratulations, Annamaria. So after the Helsinki meeting, she will become the president. And I don't have to say, I think that Annamaria served ESPGHAN for many, many years, has been a treasurer forever of ESPGHAN, had many functions, and she works in Naples and is still very active and very interested in clinical gastroenterology, so in reflux, constipation, cow's milk allergy. And she will give you a very nice talk, and it will be followed by Dr. Ralf Heine, who is now based in Australia and works as a clinical researcher at University of Melbourne and also at Murdoch Children's Research Institute. And he also has worked for Nestlé from 2017 to 2023 as a global medical director and clinical development lead in pediatric medical nutrition and allergy. And as I said, he returned to Australia. And our third speaker is Dr. Rosan Meyer, who was born in South Africa, works in London, lives in Bordeaux, and also is connected to Belgium since she is also visiting professor at the Catholic University of Leuven. So she's a very dynamic pediatric dietitian and secretary of the EACI Allied Health and Primary Section, and chair of the task force working on non-IG mediated allergy. And so she's very experienced in cow's milk allergy. So what will be the flow of the different presentations is that first we will tell you about functional gastrointestinal disorders, or now called disorders of gut-brain interaction, and cow's milk allergy, how to differentiate, and is there a role for the COMI score, the cow's milk related symptom score, and then how HMOs and lactose have an impact on the gastrointestinal microbiota, and to end up with third talk on the diagnosis and management of cow's milk allergy, when and how to introduce cow's milk. This last slide, you will see it also at the end of the presentations, but if you scan these QR codes, it will help you to get to the COMIS user guide and the COMIS tool. And without further ado, I invite our first speaker to the floor. Annamaria, please, welcome. Okay, I think they are doing it.
Excuse me. Good morning. Thank you very much for the invitation. And it's a pleasure for me to give this presentation. This is my conflict of interest, and you can see here the outline of my talk. I will first go over the prevalence of cow's milk allergy and then the prevalence of DGBI, disorders of gut-brain interaction. After that, we will look at the differential diagnosis between cow's milk allergy and DGBI. And finally, I will focus on the COMIS score. Let's start with the prevalence. Prevalence tends to vary because of different study design, different methodologies, different study populations. Cow's milk allergy may present with a variety of symptoms, most of whom are not specific, are difficult to attribute to a specific allergic reaction. And unfortunately, no single or combination of tests can help in the diagnosis. As you can see in this slide, the prevalence, if we look at the guidelines for the British Society of Allergy and Immunology, the population prevalence range between 1.8 and 7.5. But however, if we will look at the Euro-Prevail birth study based on 12,000 infants with a diagnosis of cow's milk allergy based on the gold standard for diagnosis that is still represented by the double-blind placebo-controlled food challenge, we can see that the prevalence falls down to 0 to 1.3. Symptoms of cow's milk allergy may present with a variety of symptoms in infants, and most of them are of gastrointestinal, dermatologic, respiratory origin. But they may be present also in combination. Symptom complexity may delay diagnosis, and the delayed diagnosis may have an impact of parents and patient distress, and may have also an impact on growth and development. The challenge in cow's milk allergy diagnosis is related to the fact that all symptoms, including anaphylaxis, are not specific and can be attributed to a spectrum of different diseases or other allergic reactions. In addition, infants may present with mixed IgE and non-IgE allergy. And the gold standard, as I said, is represented by the double-blind placebo-controlled food challenge, but is time-consuming and is difficult in daily practice. And so the open oral food challenge is considered an acceptable alternative. However, as we can see later, in most cases, parents refuse the oral food challenge. What about the prevalence of gut-brain interaction? Based on this study included, first of all, I want to say that disorder DGBI, formerly named functional GI disorders, are better known currently with the name of functional GI disorder, but recently the definition changed. So from now on, we should say DGBI. We can see the classification in infants, and DGBI, based on Rome 4 criteria, include disorders such as infant regurgitation, infant colic, functional constipation, and DGBI can coexist with other medical conditions that themselves result in GI symptoms such as cow's milk allergy or gastroesophageal reflux diseases. What about the prevalence? Based on this recent study, this study 2020, which included 1,689 infants from Italy, Belgium, Netherlands, and aged 48 months, with a diagnosis according to Rome 4 criteria, we can see that the prevalence of DGBI in a population 0-12 months was 24.7%. That means that 24.7% of infants between 0 and 12 months have at least one of the DGBI, such as infant regurgitation, infant colic, constipation. But it's interesting that 4.2% of them had a combination of more than one disorder. For sure, one of the main difficulties for clinicians is to make a differential diagnosis between cow's milk allergy and DGBI. In fact, most of the symptoms may overlap, not only between cow's milk allergy and DGBI, but also with other conditions such as eosinophilic esophagitis or gastroesophageal reflux disease, symptoms such as vomiting, poor growth, regurgitation, crying, fussiness. They are typical of all these conditions. But recently, the ESPGHAN published a position paper on diagnosis and management of cow's milk allergy and confirms the role of the COMI score, the cow's milk related symptom score, as an awareness tool to alert healthcare professionals of the possibility of cow's milk allergy. However, it is stressed in the paper that COMI score is an awareness score, not a diagnostic score. In fact, still now, currently, the diagnosis of cow's milk allergy, as I said before, is based on double-blind, placebo-controlled food challenge. However, because of it is difficult, as I said, in daily practice, the oral food challenge is an acceptable alternative. However, parents refuse the oral food challenge because of fear of the symptom recurrence with the reintroduction of cow's milk proteins. So, in fact, in this study, Yvan Vandenplas showed that even if 100% signed informed consent, only 73% accepted to perform the oral food challenge in their infants. So, we can summarize that the majority of infants with cow's milk allergy and or DGBI will present with a combination of symptoms. Given the high prevalence of infant colic, regurgitation, and constipation, this combination can be caused by coincidence. And one condition does not exclude the other. Once again, the recent clinical practice guidelines for the management of gastroesophageal reflux and gastroesophageal disease suggest a diagnostic elimination diet of cow's milk proteins from the diet in infant with resistant not responding to the conventional therapy, infants with gastroesophageal reflux. Based also on this study, always from Yvan Vandenplas, where we can see that 81 infants with symptoms suggestive of gastroesophageal reflux disease, not only gastroesophageal reflux. They received a treatment with 4 weeks with omeprazole. But in case they were not going to respond to omeprazole, they were fed with a cow's milk protein-free diet. And we can see that 72 had GI symptoms, 9 respiratory complaints. And it's interesting that 54 patients, 66.7 of them responded well to the PPI. However, 27 did not respond, but all 27 were able to resolve their symptoms, thank you, Yvan, when they start an elimination diet of cow's milk protein. So this just to conclude that cow's milk allergy can mimic or aggravate all signs and symptoms of gastroesophageal reflux disease, and not only gastroesophageal reflux as a functional disorders. And finally, let's talk about the COMIS, the cow's milk-related symptom score. This score, just to say, was published 10 years ago. A few days ago, it was celebrated the 10th anniversary of the publication, and is based on some symptoms that are very common. 50% of infants present at least one of these symptoms, such as crying, regurgitation, change in stool habits, skin lesion, or respiratory symptoms. And in the 10 years, 28 papers have been published on COMIS, 25 randomized controlled trials, 1 pooled analysis, and 1 review. And the symptoms, the COMIS underline once again that should be intended as an awareness tool and not as a diagnostic tool. However, the summary of this paper suggests that clinical evidence based on 28 papers say that the total score higher than 10 is suggestive of cow's milk allergy, whereas a score less than 6 suggests normal symptom. And what about between 6 and 9? And based on this study, again, from Yvan Vandenplas group, including infants 0-4 months with at least 2 function DGBI out of colics, constipation, regurgitation, we can see that the mean score for infants with DGBI was 6.46. So in this beautiful graphic, and I thank a lot Sue from Nestle that gave me this provide this graphic, we can see that a score more than 10, you can see from, unfortunately, I don't have, I cannot use the pointer. A score higher than 10 is suggestive of cow's milk allergy. A score between 6 and 9 is suggestive of DGBI, and a score less than 6 is suggesting a normal symptom, something that is normal. So the diagnosis of either cow's milk protein allergy or DGBI, and the distinction between them is challenging because no specific and overlapping symptoms. In fact, DGBI and especially non-IgE cow's milk allergy are symptoms associated with the ingestion of cow's milk protein, and the elimination of cow's milk protein results in disappearance of symptoms in both infants with DGBI and cow's milk allergy. But the difference is this, that the reintroduction of cow's milk protein results in symptom relapses in infants with cow's milk allergy and not in infants with DGBI. So this will help us. So I can conclude that based on Cummings score, we can help clinicians in making a differential diagnosis between cow's milk allergy and DGBI. There are many clinical evidence supporting this data that Cummings score is an awareness tool and is a useful tool for clinicians. And I thank you very much.
Thank you very much, Annamaria, for this very nice talk. And we move now to the second presentation by Ralf Heine about unleashing the power of the microbiome.
Sorry. I'd also like to thank the organizers for inviting me to speak onto the role of the microbiome in cow's milk allergy. So I've been given a big title, Unleashing the Power of the Microbiome, and I will take you on a guided tour. There's already been a lot of interest in the microbiome during the meeting, and many of you will already have heard about the importance of the microbiome in cow's milk allergy. I'd just like to take a step back at taking you through the importance of the microbiome, because the microbiome is an important modifier of disease risk from birth and throughout life. On the left side in the panel in blue, you see a healthy microbiome really made up of bifidobacteria and healthy commensals that set up an environment that is high in short-chain fatty acids and that maintain the barrier function perfectly. And you can see here the happy epithelial one-cell layer with a mucus layer, and in the submucosa, in the lamina propria, there are some regulatory T cells that keep order of immune responses. So this is a very controlled and orderly state. By contrast, when we have a dysbiotic microbiome, and this is a microbiome where there's a lack of bifidobacteria, where proteobacteria overgrow bacteria like E. coli or Klebsiella, we see a breakdown of this barrier function, and we see that it becomes permeable both for bacterial antigens and also food antigens. And that leads to a breakdown of homeostasis in the submucosa, and we see a chronic inflammatory state with a predominance of Th2 lymphocytes, so predisposing to either allergic sensitization or maintaining allergic responses. So how do we end up with a healthy microbiome? And unfortunately, that is not an easy answer, because you can see it's multifaceted. And it really depends from birth on what is the microbiome that's passed on to the baby, or when the baby is born by a cesarean section, what is the microbiome that the baby inherits. Feeding mode, obviously, breastfeeding versus formula feeding is important, and then other modifiers like environmental factors, perinatal antibiotics, and also maternal lifestyle and diet. All of this impacts on the infant microbiome. So how do we really find strategies to effectively modulate the microbiome, maintaining a healthy microbiome or shifting a disordered microbiome back to health? This is data from the TEDdy study, which was a large birth cohort study, and they analyzed over 12,000 stool samples in a large cohort of infants. And you can see that they broke down the risk factors for, or the important modulators of microbial composition by age group. And when you focus here on the age groups under 12 months, you can see the biggest contribution to a healthy microbiome or to microbiome contribution is from feeding modes. So breast milk being one of the most important modifiers. And why is that? So much of the components in breast milk are human milk oligosaccharides, and human milk oligosaccharides are probably the single most important factor in breast milk because they provide the specific substrate for the early microbiome in infants. And this is now becoming also relevant for the management of cow's milk allergy because some of these HMOs can now be made synthetically and can be added to hypoallergenic formulas. So what are HMOs? And I won't bore you to this audience. It's well known. These are complex carbohydrates. And the important thing is that they can't be absorbed by humans. And I explain why in a second. So these are bioactive compounds in breast milk, and they foster a healthy microbiome rich in infant-type bifidobacteria, and that also fosters the arrival of other related bacteria that interact with bifidobacteria. Why are HMOs different to other prebiotics? So when we think about prebiotics, we know that they promote the enrichment with healthy bacteria, gut bacteria. And previously we've seen hypoallergenic formulas, for example, supplemented with GOS and FOS, galacto-oligosaccharides and fructo-oligosaccharides. And human milk oligosaccharides are really the latest arrival. When you look at the chemical structure, they're actually very different. And you can see the HMOs are made up of more complex structures that also contain molecules like fucose, and not shown here on this slide, also sialic acid, which is important for example, brain development. So HMOs are very multifaceted, and because there's so many of them, they probably have very distinct functionalities with some redundancy in the system. Galacto-oligosaccharides and fructo-oligosaccharides are different. They're long-chain sugars made up of galactose or fructose. And just as an aside, fructose is actually not part of the breast milk composition. So fructose is something that would maybe appear later in the diet, and the early microbiome is maybe not expecting fructose as a substrate. So this is a typical infant-type bifidobacterium, and this is an important distinction I would like to make because infant-type bifidobacteria are not just any bifidobacteria. There are thousands of different bifidobacteria in humans and in animals, but human milk oligosaccharides are just a select few, and you can see on the right side the different ones. So Bifidobacterium longum infantis, also short called of B. infantis, or B. breve, B. bifidum, and Bifidobacterium longum. So these are the 4 prototypes of infant-type bifidobacteria, and only these are specialized in dealing with human milk oligosaccharides. So when you read about bifidogenic effects, be specific about which bifidobacteria are actually amplified, and is it the right ones that are important in early infancy. So these bifidobacteria can incorporate or channel human milk oligosaccharides into the inside of the bifidobacterium, and they have specialized enzymes that we don't have, and you can see the list of enzymes there that can break down the HMOs completely to the molecular level and then ferment it, gain energy, and then they produce lactate and acetate as their main metabolites. And lactate and acetate in turn are then often converted to butyrate and propionate, other short-chain fatty acids, by friendly cross-feeding bacteria. And this is an ecomilieu that sets up an environment that is acidic, so this prevents from gastrointestinal infection and invasion of pathogens. And so this is the hallmark of the early gut microbiome. Just a quick reminder that butyrate is at the core of tolerance development, very relevant, obviously, to cow's milk allergy. So butyrate has 2 main target organs. One is the colon, the gut itself, and we see here that it maintains gut mucosal integrity in the colon particularly, but it also has an impact on the immune system and can directly interact with immune cells and, for example, upregulate regulatory T cell responses and downregulate inflammatory responses, similar to what we've seen in the unwanted effects of a dysbiosis. Once butyrate appears, we see some calming effect in that setting. And a new kid on the block are aromatic lactic acids. This is a new compound that is deserving interest because it's also immune modulating and may have a role in immune defenses and early immune development. And this is something that's particularly made by infant-type bifidobacteria, not by other bifidobacteria. So again, something why the distinction is important. Just want to digress slightly on lactose, because lactose is a neglected and often misunderstood compound in breast milk, and it's actually the biggest milk solid that we have, so it's 52% of milk solids. Lactose can be utilized by bacteria, and you can see there the lactose fermenting bacteria like lactobacilli, but also some bifidobacteria, E. coli, some of them can utilize lactose. So lactose is also a substrate for bacteria, and remember that some lactose in young infants will reach the colon due to physiological lactose malabsorption. And again, bacteria will then make lactose into lactic acid, some gas, and for example, lower the stool pH. And this is the reason why breastfed infants have a low stool pH around 4.5 to 5. And often now in Western countries, we see that infants have a stool pH that is much higher due to dysbiosis. I will quickly just mention also that the effect of lactose has been assessed in cow's milk infants, in healthy infants, infants with suspected cow's milk allergy, And these were treated with an EHF with or without lactose compared to those who received breast milk. And you can see that bifidobacteria, for example, are increased in the light blue compared to the dark blue. So this is, again, the bifidogenic effect that we like to see in infants. And lactose also, not shown on this slide, increased short-chain fatty acid production. When lactose is combined with HMO, we actually see additive effects. And this is data from an ex vivo fecal fermentation study where stool samples from infants with cow's milk allergy were incubated over 48 hours and then samples taken successively. And you can see for all three short-chain fatty acids, acetate, propionate, and butyrate, that there was an additive effect that was highest when lactose and HMO were combined. And these are the two HMO, LNNT and 2FL. And you can also see in the HMO-utilizing bifidobacteria on the right side that the abundance of bifidobacteria of infant type, these four are all considered HMO consuming, are the highest for the combination. Why lactose in cow's milk allergy? Is lactose safe in cow's milk allergy? And the answer is mostly yes. There's one exception, which is the cow's milk protein-induced enteropathy, where there's actually mucosal breakdown and loss of disaccharide activity. And once that's been restored, lactose becomes okay, but IgE-mediated cow's milk allergy and FPIES and also would be okay with lactose if it's given in a medium that is otherwise appropriate. So the very severe ones, so for example, amino acid formulas don't contain lactose for that reason, but extensively hydrolyzed formulas with lactose provide a benefit in that context. I'm just very briefly going to mention two clinical studies that have looked at the effect of an EHF supplemented with 2FL and LNNT. So this is a whey-based, extensively hydrolyzed formula with lactose and two HMOs. It was primarily a growth study, but it also looked at secondary outcomes. And I'm just going to remind you of the effect of HMO supplementation on infection rates. This is a follow-up study on a healthy infant study, which demonstrated the Puccio study, which many of you will know. And this is a follow-up study in cow's milk allergic infants in 200 infants who are randomized to receive an unsupplemented EHF versus that contained the two HMOs. And you can see that for lower respiratory tract infections, otitis media, and gastrointestinal infection, there was a significant risk reduction compared to the control group. None of these reached significant levels, and that was due to the study being underpowered for the secondary outcome, but it supports a trend similar to what was seen in the Puccio study. So the reduction in infection rate is in keeping with what we see in breastfed infants as well, and what we've seen in healthy infants with HMO supplemented formulas. Why is this happening, and what are the mechanisms? So this is a slightly complicated slide, and I will, in the interest of time, go through this fairly quickly, but it looked at the different development stages, and on the left side of the panel you see the fecal community type clusters 1 to 5, which summarize the composition, and the gray above those, each bar, are the other bacteria that colonize. So we see a diversification. The early colonizers were 12 early colonizers, and then we see that more and more bacteria come in with successively as part of diversification. And in the middle panel, you can see that there are differences in how infants with or without HMO progress through the different stages of maturation towards 12 months. And as an interesting observation at visit 6, you can see that the control group was almost half already at fecal community type cluster 5, which is adult-like, whereas the HMO group was still lagging behind, and this was at this stage significant, suggesting that the infants that had HMO supplementation stayed in a more immune modulatory window period for longer. So this progression into an adult type, or premature progression to an adult type, is halted by HMOs. Just to remind of the bifidobacteria, so this looks at the effect on the microbiome composition, and we can see in this slide that in the HMO supplemented group, the enrichment with bifidobacteria was including the 4 infant type bifidobacteria that I mentioned earlier. In terms of metabolic signatures, I'm just showing you the fecal acetate production levels. In the control group, there was a reduction in acetate, so acetate production mostly from HMO utilizing bifidobacteria was reduced, whereas in the HMO supplemented group, we saw that acetate production was increased. This did not quite reach significant here because of the large age gradient at enrollment, so we had infants from 2 weeks to 6 months, and there was a diversity in responses, but it underlines that acetate production was increased, at least from visit 0 to visit 1, which was the 4-week follow-up. Later in the study, when diet comes in and fiber comes in, these differences are much harder to see and interpret. And this is another single-arm study in 32 infants with moderate to severe cow's-milk allergy who required an amino acid-based formula. This is, again, primarily a growth and tolerance study, but also looked at the microbiome. And you can see here the effect on the HMO-utilizing bacteria, the bifidobacteria with 2FL and LNNT supplementation. This is a lactose-free formula, just in difference to the previous study. And you can see at V0, we see a broad range, really, but there's a bimodal distribution, as you can see. There's some that have sort of some bifidobacteria, and at the bottom, there are about 1/3 of the population who did not have any mentionable bifidobacteria in this that could utilize HMOs, and that also explains why we have a bimodal distribution after 4 weeks. So we have some who enrich very nicely, but there is this remaining group that did not amplify, and this indicates that some infants with cow's milk allergy may have a highly deranged microbiome that is not able to effectively utilize HMOs, and that might point maybe to a symbiotic intervention as a way around that. So in summary, I think I've showed you evidence that the supplementation of hypoallergenic formulas with breast milk identical HMOs has immunological benefits, and that included, for example, a reduced rate of infections in the first year of life, that the gut microbiome from the 2 studies in cow's milk allergy benefited from HMO supplementation and induced an early enrichment of HMO utilizing, so infant type bifidobacteria, and also associated metabolites, mainly short-chain fatty acids in our study. The ex vivo fermentation experiments also showed that there was most likely a beneficial effect of combining HMOs and lactose. And finally, the big aspiration is really to see what HMOs can do in modulating or modifying the cause of disease in cow's milk allergy. And that may also apply to the use of HMOs in allergy prevention. So this is probably the next frontier. Can we modify the microbiome back into a healthier state and accelerate outgrowth from cow's milk allergy? I leave that as a thought. Thank you.
Thank you very much, Ralf. And then we move to the last presentation by Dr. Rosan Meyer on the reintroduction of cow's milk into the elimination diet. When and how?
Thank you, Yvan, for that introduction. I'm also like to thank the organizers for inviting me on a topic that's very close to my heart and amazing to follow such eminent speakers. I want to start with my conflict of interest, which includes an honorarium for today's presentation. Now, if we look at the natural history of IgE-mediated cow's milk allergy, just to remind everybody, that's the immediate type allergy, the one that normally within an hour you have very immediate type symptoms. If you look at the different the natural history, you've got a wide variety of studies showing natural history based on oral food challenges. What has become very clear looking at a study from last year is those that had persistent cow's milk allergy, of course, were those with higher IgE levels, those with a history of anaphylaxis, and those who've had complete cow's milk elimination. For the last 10 years, I would have, and even longer, the discussion has been, would therefore an earlier exposure make a difference? And the question is, do you expose before the age of 1? There. Do you go when a child already has had allergies for 2 or 3 years? Do you go in there? Do you only focus on your population that have persistent allergy? Do you go in there? So it's all a question on when do you start intervening? And I suppose for us all in the allergy world, there was a bingo moment when Anja Novak in 2008 started to publish the work on baked milk, and I've got here a muffin and a waffle that was initially the baked milk foods that were used. We've migrated more to the muffin than to the waffle. But in essence, what the many publications have shown from Anja Novak in 2008, and then also Kim that had Anja Novak within the team in 2011, is that baked milk was tolerated by many of the children with cow's milk allergy. So you can see tolerance ranging from between 68% and 75%. And in one of the studies has shown really that if baked milk was tolerated, that they were 16 times more likely than the comparison group to actually also start outgrowing the allergy. We can have a different discussion around control groups, but it got us all very excited. And we're thinking, well, if baked milk works, then why don't we just push the boundaries? We go to pizza, we go to Parmesan cheese, we go to yogurt, and then why don't we just do milk? And that is really how milk ladders were born. The first milk ladder was born in the UK, and that was with Karina Fenter. At that stage, I was not involved. It was a 12-step ladder. It was very much a pragmatic approach at that stage, not research managed at all. But in all of the milk ladders, certainly that I've been involved, we have a proviso says that a milk ladder should not be used in IgE-mediated allergy. It's in bold. It should be used in non-IgE-mediated allergy. However, we were all so aware that milk ladders were slipping through for IgE-mediated allergy and were used, and we were all feeling extremely uncomfortable about that. Until 2022, Jonathan Hurain from Ireland published a study where, because they run a service that's extremely under pressure with all of these children with cow's milk allergy that were not challenged in an age-appropriate way, and often were 3-4 years of age and still eliminating cow's milk. So what they did is a randomized controlled study, 2 groups. These were infants below 12 months, and that's really critical. So you have maximum immune plasticity, that an intervention group of 40 children, and in the one side that received the milk ladder at home, and I'll come to that, and then the other group was just standard, you eliminate cow's milk as standard practice. Now, if you look at the mean skin prick test of the intervention group, was close to 6, and you've got a specific IgE of 11.3, so I wouldn't say low, and similar for the group that was the control group, slightly lower IgE. The group that received the milk ladder at home received an EDO5, so eliciting dose of where 5% of children reacted, a supervised challenge, with the hypothesis is that those children that passed that challenge would not be those children that had those severe reactions. They were then sent at home on the 12-step, so not the 6-step milk ladder, but the 12-step milk ladder. They looked at the state and trait anxiety inventory, and also food quality of life assessment as well. And the results were quite interesting. They did an assessment at 6 months and an assessment at 12 months. And at 6 months of age, you can see already the group that had the early introduction were already on the step 6 of the ladder. That's the lasagna step on the old 12-step ladder, just for you to know where you are. And step 12 is tolerating milk. So 30% of that group already tolerated milk. And then they did the same at 12 months. So you could see step 6 lasagna was very similar, but you had a very significant difference that at that stage, 12 months after, significant number were tolerating cow's milk. Your first question is, how many of them had severe reactions? And in fact, it is not a zero risk, because there were mild reactions. I've experienced them. We have been doing that for more than a year, so you get some hives. There were 3 children that had accidental exposures to steps much higher, so they had more worse reactions, but they were not following the protocol. What is a very important message to all of you? I do not want you all to run off and saying, oh, this is great, all of my IgE-mediated patients are going to have the milk ladder at home. As you could hear, there's safeguarding around. You have to make sure that you challenge them. But I want to remind you that anaphylaxis and baked milk challenge, and Ralf, Heine and I were just discussing, we all have had pretty hairy experiences. So please, if you do decide to do this, pick your population very carefully. Think about whom are you going to do that. So then the last step would be, okay, what about, it's done, the child is 6 years of age, still has cow's milk allergy. So the DRACMA guidelines has got one of the guidelines which really looked at all of the oral immunotherapy. And in essence, they said it's a balance. It's not a zero risk procedure. So in those where the benefit of having milk outweighs the side effect, then you'd want to do not a baked milk oral immunotherapy, you do milk oral immunotherapy. And converse, if somebody's saying, actually, it doesn't make a big difference in my life, you're not going to go into oral immunotherapy. Now, for all of us working in allergy, it's very interesting. This was published in 2022, and they already talked about omalizumab. That was prior to the Xolair publication, the FDA approval that came out. And of course, we do have exciting data. Just last week, before I get to that, this is conditional recommendations, but last week, the UK studies, the Natasha-sponsored studies, brought out the new very exciting study on oral immunotherapy on peanut, but also cow's milk as well. So let's move to non-IgE-mediated allergy. So you can see we have several phases of intervention, and we are moving towards early introduction in IgE. So what about non-IgE? Non-IgE, the graph looks different because we don't have that many studies that used an oral food challenge to look at the natural tolerance. In yellow, you've got the Europreval study. 100% of the Europreval patients with non-IgE-mediated allergy were tolerant. Then you have some other studies from David Hill, you've got from Vanto. They all looked at different ages. But overall, you could say that non-IgE-mediated cow's milk allergy, it's expected that tolerance is achieved earlier. But there's much less data on oral food challenge. So a lot of it is observational, not the data that I've mentioned here. So when we look at guidelines, most of the guidelines say okay, you've got a child that is diagnosed with non-IgE mediated allergy, you've confirmed it, so it's around 6 months after, avoided until 9 to 12 months, but all of this is really consensus-based. It's not that we have a really good database to say this is the time of introduction. When you come to the FPIES guidelines, the US data says around 18 months, 12 to 18 months after. But again, this is not, it's just based on the US. And in EOE, rescoping occurs and reintroduction really occurs depending on the centers. So one of the aspects that is still very confusing, and I can't reinforce that as much as that, there seems to be confusion in terms of confirmation of allergy and reintroduction of foods. So please be clear that a non-IgE mediated allergy, you do not have a diagnosis until you've reintroduced. So you don't go from, oh, I think this child has got a non-IgE mediated allergy, I'm going to wait 6 to 8 months and then going to do a reintroduction. You do need to do the confirmation. That is normally around 2 to 4 weeks after. I'm just shown our protocol from the IMAP, but there are very good protocols to do that. And of course, then there's the reintroduction. And here, the reintroduction, as I said to you before, we did intend to use the ladder for home reintroduction, not confirmation. So for all of those of you that have used the ladder for reintroduction at home, I want to kind of highlight the negatives and the positives. The positive is you have a very soft and a way of introducing, and parents feel quite comfortable with it, especially those that don't want to do it. But we published from our data about 3 years ago the number of attempts to having to do this at home. So if you look at this, hopefully I can get that right. No, there's no pointer here, maybe the mouse. If you look at the reattempts for each step for partially tolerant, you can see, for example, here 2 to 5 attempts in many of the patients that we needed to show on some of the steps. So one of the messages here is, if you have a parent that says to you, oh, my child didn't pass the milk ladder, do it again. Retrial it, because there can be a cough, there can be a cold. You need to constantly be at it. So it is very labor intensive. This is where I have found doing the COMIS score quite useful, in that you can really have it as a monitoring tool when you do your reintroduction. So what I normally do is to the parents saying, wait until your child is not teething, until your child is not sick, do the COMIS, then start with the milk ladder, and then show me objectively what is getting worse. And then I use that to monitor them. I'm going to come to my second last slide so that we have some Q&A time. What we think is quite exciting is that we have noticed, observationally amongst us, that many children with FPIES to milk seem to tolerate baked milk. And Fettelson in 2023 brought a lovely article out. It's observational, where they challenged, it's only 13 patients, and found that the vast majority tolerate baked milk. And so within the DRACMA guidelines that we wrote on the elimination reintroduction, we now have a table where we debate doing baked milk in children with FPIES, where we're saying it's typically you'd want to think about doing in a supervised way, but if you decide to do it at home, and again, please make your risk assessment, you really don't want those patients that had the most severe form of FPIES. You have the pros that you can say, okay, quality of life, it helps the patients, but we have no idea, absolutely zero, whether if baked milk tolerance in FPIES means that you become tolerant faster. It's really at this stage something very exciting for us, just to say it has the potential to actually improve quality of life. You can read through our publications where we will provide all of the further discussion around that. So if I conclude that the timing of reintroduction of cow's milk is better established for IgE than for non-IgE mediated. And for IgE mediated, we have really now, instead of a watch and wait approach, we have a much more active approach where we're thinking possibly during the immunoplasticity phase, it might be much more beneficial. If you do decide an IgE-mediated allergy to use baked milk, that, of course, please be aware, needs to be supervised. There is a risk to there. And in terms of the ladder, it's very exciting, but please do not just initiate it. The way we use it would be you have your low dose challenge, and if you do not pass it, you do not progress with the milk ladder with an IgE-mediated allergy. With non-IgE-mediated allergy, you've got this consensus around 6 to 12 months, at least 6 months after the elimination, but I kind of tend to go and saying, look, if it's proctocolitis, I lean to it earlier rather than later. So think about the patient that you've got in front of you and not just follow a guidance. The ladder approach is commonly used, but you may not want to use it. You might have a different practice. It's just relieving us, but if you use it, think about the repetitions you might need to do it at home. Don't just take it as face value, the child failed. Go and say, let's try that step again. And I think the most important message is train anybody that does any of this at home or in the hospital. You have to have compliant parents. And if there's one thing that I've learned is that your guidance, whatever you do, needs to be as clear as possible to parents. I thank you very much.
Thank you very much, Rosan, for this very informative lecture. And may I ask all speakers to come here on the podium. There are empty seats here in front for those standing up over there. Please come take a seat here. And we have 7 minutes for questions. So please come to the microphone if you have a question. I see no one coming to the microphone, so Annamaria, what, in your opinion, is more of a problem, over or underdiagnosis?
I believe that for sure could overdiagnosis, but on the other hand, in clinical practice, is a useful tool because in order to make the diagnosis, you need the involvement of at least 2 different apparatus or systems, such as GI, respiratory tract. So I believe that is an accurate tool if is interpreted in the right way. So.
Thank you very much. Then please state your name and where you're from and ask your question.
Yeah, good morning. I am Dr. Pinaki Chakravarti from India. My direct question to Dr. Heine about the HMO and the CMPA. If we increase the number of HMOs, because already 2FL and LNT are there, if we add the number of HMOs, so will it reduce the incidence of the CMPA further? So it has any direct proportionality with the number of HMOs added and the reduction with the CMPA?
Yeah, thanks for that question. That is the idea, I think, and that's what I think with increasing feasibility technically to make other HMOs, we will probably see an expansion of the spectrum of HMOs that can be used, and we've already seen that in healthy infants. There are now infant formulas with 6 HMOs, and due to the diversification and maybe also increase in dose, you might see a greater impact on the microbiome and with related metabolic and health benefits. So I think it will, whether it will reduce the rate of cow's milk allergy or accelerate outgrowth, I think the studies will have to show that. But I think that's the aspiration, I think.
Okay, thank you.
Yes, please.
Hello, thank you so much for this wonderful parallel symposium. I'm Ruža Pančeva, I come from Bulgaria. Our group was involved in the testing of commies above 6 months of age. Still, Professor Staiano, what would you say about the specifics of the use of commies above 6 months? This is the first question. And the other is, what about the practical diagnosis of dysbiosis? Does it have anything to do with cow protectin, zonulin, or other tests? Thank you so much.
Thank you for your question. COMIS has been already validated for infants less than 6 months. Now studies are going on to validate also in infants between 6 and 12 months. So I believe that in the next months, by the end of the year, we will have also these studies. So thank you.
Maybe just on the question of the dysbiosis and how do you recognize dysbiosis. This is not easy, and I think if you have advanced research tools and can do deep sequencing and all that sort of thing, then of course that's easier. But I think at the personal level, it's not so easy as at the group level. I think we have better tools. One indication could be the stool pH. I think if you have a stool pH that is around 6 or that indicates that you don't have a lot of bifidobacteria and short-chain fatty acids going on. So that could be an indicator of dysbiosis. But I think we need better tools because if you want to screen babies maybe at an early age for risk of NCDs and inflammatory disorders, that's maybe something of the future. Yep.
Thank you. It's 9 o'clock, so 2 short questions and short answers, please.
Hi, I'm Nicole. I'm a dietitian from the UK. Thank you all for your presentations. They were all really, really good to listen to. Just a quick question for Rosan. With the milk ladder, when you were saying to re-challenge, is there any evidence just in regards to how long to leave after the child sort of fails at a step? Or is it sort of individualised based on the child's symptoms at sort of the time of onset and the severity of the reaction?
So there's no evidence. The pragmatic approach that I use is if the failure was because there were confounding factors, they were unwell and all of that, I do it quite quickly, to be honest, after. If it was a real failure, for example, it was very clear, I normally, depending on the age, if they're younger, I would really think about 6 to 8 weeks to try it again. And so I'm a bit more aggressive from that, but I do not wait 6 months, for example.
So quickly, if you could define that.
How do you mean?
If they didn't have a very severe reaction when you said you're quite aggressive and you'd do the next challenge again quite quickly, would that be within a week, 2 weeks, or days?
So if they had not, I would say if they, for example, on the COMIS scored, say, 18, 19, that's quite useful, then I would do 6 to 8 weeks after that again. And it depends on which stage, of course, on the ladder they failed. If they've failed on stage 3, I make sure that they have the previous stages in their diet.
No, that's really helpful. Thank you.
Good morning, Maurizio Menini, Sapienza University. I appreciate the description and the differences between the functional disorders and the cow milk allergy, but I would like to ask if probably it is now the time to coin a new way to call the cow milk allergy, not IgE mediated, as something related to cow milk protein, but not an allergy in terms of immunological disorders, I mean. Because it is well demonstrated that COMIS score works and so on, but probably it is just a way to call it. I don't know what do you think about it. Thank you.
He's looking to you.
It's looking to me. Okay. Well, I think from the clinical point of view, it's often very difficult to make the difference between disorder of gut-brain interaction and non-IgE-mediated cow's milk allergy, because we have no clear diagnostic test for non-IgE-mediated cow's milk allergy. Also, if you do an oral food challenge and you have to wait 3 to 4 days before your symptoms develop in non-IgE-mediated allergy, how will you make the time relation? And for me, the biggest weakness of our golden standard is that a positive oral food challenge does not show in any way that your immune system is involved. It's clinical reaction.
Yes.
So if you want a Nobel Prize, please find a good diagnostic test for non-IgE-mediated cow's milk allergy.
Okay. Thank you.
Can I just add to that? If you really have the desire to make your life complicated, you can look at UTL has published a new nomenclature from IACI in November.
Yes.
And that would be lovely. It goes down the Coombs, the diagnosis, so now it's cell-mediated. It's type 4A, type 4AB, and it's also tissue-mediated. So yes, there is a way, but it makes it very complicated.
Yes, thank you.
Thank you very much.